All right, thank you all for joining. Good morning, good afternoon from wherever you may be joining us from. My name is Jody Rodney, and I am the Vice President of Marketing and Education for Plan Mecca USA. This is the 11th in our Plan Mecca Digital Mastery Series. We've had a lot of fun. We've had a lot of great courses and presenters and programs. So hopefully if you've joined us for our previous ones, you've enjoyed them so much and you're back for more. For those of you who this is your first one, thank you for coming, and hopefully you'll take away a lot of information from Erin. Erin has actually presented this a few times to our own sales teams and really helping inform our dealer partners and helping educate them on how they can help the road to recovery past COVID-19. So with us, as I mentioned, is Erin Marcum. She is a Plan Mecca District Sales Manager covering Tennessee and Kentucky. Before we get started, I do have a few housekeeping items. One, all attendees are muted. If you have a question for Erin specifically, please submit that via the Q&A. If you're having any audio or AV issues in general, please submit those via the chat feature. Again, questions for Erin or for Plan Mecca, please submit via Q&A. Issues, please submit via chat. At the end of the presentation, we will have a link to the CE survey. It'll be included in the chat along with the CE or the AGD code. We are also sending out an email with a recording of the presentation as well as a CE link. So if you're having any issues at the end with your link, please note that you will get an email by the end of today or tomorrow morning. So without further ado, I'd like to hand it off to Erin.
Okay, thank you. So yeah, like Jody said, my name is Erin Marcum. I am a Plan Mecca District Manager. And what we're talking about today is how do we make up for our financial losses once we can come back from COVID-19. Hopefully I will only be going for a little less than an hour, and then we will leave enough time to do some question and answers. So we're going to fly through this. There we go. Okay, so the disclaimers here, have to mention these. The information contained in this webinar and related materials is provided for informational and discussion purposes only. All information is provided as is. Plan Mecca does not assume any liability or responsibility in the accuracy, completeness, or materiality of the information. Hopefully I said that word correctly. Plan Mecca is not liable for any claims, losses, or damages of any kind arising out of or in any way related to the provided information. Plan Mecca is not a dental or medical coding company, nor claims to have subject matter expertise in this area. Plan Mecca does not advise dental or medical professionals on how to file insurance claims. And then the last one is that the information provided is not intended to constitute legal advice or the rendering of legal, consulting, or other professional services of any kind. Users should seek the services of a competent legal, tax, financial, and other professional for such advice. Okay, so here we go. So just quick introduction of myself so you know who's in front of you, taking over your computer screen for the next hour. So in the 2000s, I graduated from Purdue University, go Boilermakers, with a bachelor's in business as well as a concentration in pharmaceutical sciences. I started out getting my doctorate in pharmacy as a pharmacist and worked in a pharmacist as part of that program, and realized I did not want to work in a pharmacy. So even though I knew I didn't want to do that, I was still a certified pharmacy technician. But then for 3 years at Purdue, I was an assistant teaching assistant in accounting. And you'll see how that goes into play in a little bit, because I had to figure out a way when I got into sales how to bring my accounting background into it, to make return on investment spreadsheets, to see just financially how the technology that I was promoting to my customers affected their bottom line of their business. Once I graduated, I worked for a company, a privately held company, Faring Pharmaceuticals, and I sold orthopedic and urology devices there. And then I'm also an adjunct chemistry professor. I did that for 8 years at Indiana University. So I made the switch over. So because of that, I'm very much an educator. I'm very much someone that will back up what I say with statistics, educate my customers on what is going out in their environment, what's going out on the field, and again, back that up with statistics and research, and then you can take whatever you want from that information. In the 2010s, I was a digital technology specialist. I was also a specialist for CAD/CAM technology, and I actually invented and implemented during this time a return on investment analysis that is now used nationally for consultant practice analysis reports. And we are actually going to go over that today, and Planmeca reps are able to give this analysis to you at no charge, and we'll go over that today to see if certain types of technology do make sense for your bottom line. I worked on the clinical side as well, so I am a CAD/CAM trainer, as well as I've worked with the Trios products, and I was also a board member for Ascension Health Network out of Indiana, which is the largest health network there. With that experience, I got a lot of background in what happens with insurance, what you as doctors deal with, and what patients deal with as far as insurance goes, and how we can use technology to maximize our insurance benefits, and using the little that they give us and the little that they pay us, how we can use that to our advantage. And then in 2016, I joined Planmeca and held multiple roles within Planmeca, both on the CAD/CAM side and the imaging side. And I'm still with Planmeca today. So just came up on my 4th year anniversary. So what is going on today? Okay, so we have a lot of time for clarity. I'm actually reading a book right now, and it's called The Cleanse for Clarity, or the Clarity Cleanse. And what it tells us is that in the modern life, with the technology and how fast-paced we are, our life is not conducive to clarity. And because of what is happening today with having to stay at home, we are now forced into a time of clarity. And what clarity requires is space and slowing down, and we then can make sense of our experiences and what we want our lives to be. So this is a great time, and I know a lot of other people have preached it, but this is a great time to really sit back and figure out, with your business as a dentist and with your work-home life balance, to really take a step back and say, what do I want my business to be like? What do I want my patient experience to be like? What do I want? Do I want to work harder? Do I want to work smarter? Do I feel like I'm drowning? And we can really get a sense of clarity if we use this time effectively to see that we're not stuck, and that our circumstances in our business and our home life are not fixed, and we're not set in our ways. So that has really set up our why for today. So I know that you are nervous. I am too. And I know that you've lost a lot of money. And we, as a dental manufacturer, completely understand. Trust us, we have too. So because if you're not working, that means you're not buying anything. And if you're not buying anything, then dental manufacturers aren't producing anything. So we are right there with you, and we understand what you're having to go through. And so now more than ever, with this whole clarity shift of what you want out of your practice, you have to be more efficient in your procedures. And how do we do that? How do we gain clarity around that? We have to learn how to maximize our patient appointments and chair time. Again, with our insurance benefits being decreased, how do we maximize our patient appointments and chair time when we begin seeing patients again? How do we lower our overhead, and how do we increase our production? So we really, as a dental community, have to figure this out quickly, and how to change this shift in our practice to achieve these 4 things. And so what I have figured out is that when you purchase technology, you have to first figure out, why do you, the dentist, need CAD/CAM, and why do you need imaging? That's what we're clearly going to be focusing on today. And by imaging, we're looking at extraoral imaging. can it do those 4 things that I just mentioned for you? Why do you want it to do those 4 things? And then once you figured out like your why do I need this technology in my practice? Then you figure out, okay, well, why do I need to purchase this technology from Plan Mecca? Yes, while I work for Plan Mecca, I am not honestly here today to promote a lot of Plan Mecca products. We will be talking about them and how they can help you achieve the first why. Why do you need this technology? But this is more around how to use your current technology in your favor to achieve those 4 things, with maximizing production, lowering overhead, maximizing patient chair time. But I'm not here to show you everything that Plan Mecca can offer. What I'm here to do is just, why do you, the dentist, need CAD/CAM technology in this current time? Okay, because if I were to start out and tell you that you need to Plan Mecca first, and I didn't know the why behind it, that doesn't work. You would never purchase anything. And then you as the dentist wouldn't know how you would need to use this technology. So we have to figure out the first, why do you need CAD/CAM or imaging in your practice, extraoral imaging? And then the second thing is, why do you need to purchase from Plan Mecca? But again, that number 2, we're not really going to get into today. Okay, so the first thing is, why do we need to purchase CAD/CAM or technology? Is that we need to make the biggest piece of the pie more profitable, and that's exactly what these technologies can do for you. So when we get back, hopefully in May, fingers crossed, when we get back into the office and get back to our normal life, really to maximize production and really to lower our overhead and get the biggest bang for the buck, we have to focus on the biggest piece of the pie. And for a general dentist, if you see here, hopefully you can see my my mouse here, but restorative dentistry is the biggest piece of the pie typically. So for this specific office, it makes up 38% of their practice. The national percentage of restorative dentistry is 36%. So my suggestion to you as the dentist is to really focus in on your restorative dentistry and to get clarity around that. Again, what are you trying to do with your practice? What differences do you want to make? And then how do we take the restorative dentistry to create an outcome around that why? Because if you say, you know, I want to do more implants or I want to do more endo, well, what's the why because of that? It's probably because you're trying to increase production. And I'm not saying to not do implants and not do endo. However, if you look at this, if you add implants to your practice, that's only about 6% of your overall production. If you look at endodontics as a GP, that's only 3.6%. You're not going to see, again, if we're trying to make up for things that we lost, I don't know if something that equates to 3% of our practice or 6% of our practice is really going to help us get there quickly over the next, 6 months. So really today we're focusing in our restorative dentistry. So again, I know sometimes when you talk about your sales reps, or if you talk about your dealer rep or even a manufacturing rep, you think that we're just trying to tell you something, and of course we want you to buy something, but we just like you want to perform dentistry on patients because that is what makes you money, but you want to help patients first, and we want to do the same things. It's our job to help you as the dentist. And so how can we help you make the biggest piece of the pie more profitable? So Gordon Christensen says, and he's Jesus of dentistry, anything that he says, we go by. And what he says is 30% of a GP's production will come from restorative dentistry. Again, there's other reports out there that I just told you, that I just showed you, that said 36%. So 30 to 36% of your production will come from restorative dentistry, biggest piece of the pie. But then when we narrow that down and we see that 30 to 36%, 90% of that dentistry is single unit restorations. So when we look at making the biggest piece of the pie more profitable, we need to look at how do we maximize our single unit restorations and the production around it. Okay, so because if we focus on that, that is how you are going to hit the ground running. Yes, do your implants. Yes, do your endo. But again, guys, we're trying to make up for lost time and we need to hit the ground running. So we need to focus in on those single unit restorations because that's the biggest piece of our pie. Okay. So how do we do that? We've got a couple of options. We can do more dentistry. We can do more single unit restorations. We can diagnose more. Okay. So that's our first option, and we'll get into this. So I'm gonna show you what the problems are, and I'm gonna show you how to move forward from them and to really, like I said, gain clarity around them, and how to fix any problems that you may have. So we can diagnose more single unit restorations. Our option B is that we can charge more. And honestly, this isn't a great option because 82 to 85% of our patients are on PPOs. So of course, PPOs tell us that we can't. And even if we were a fee-for-service practice, what you would have to charge in order to actually see a decent profit and hit the ground running would never financially make sense for your patients. So, and I'll get into that later, but charging more, possibly, you probably do want to look at your fees and if you need to adjust them, but you're not going to get the biggest bang for your buck there. Okay, not saying to ignore it, something to look into, but we got to act quickly. So option C is that we can be more efficient and profitable in the dentistry that we are currently doing. So if we take our current patient base, and this is where we maximize our patient appointment, and if we can sit that patient down and we can do more quadrant dentistry on them, we can use the time more efficiently that they're in the chair, we can lower the overhead around that dentistry, that is where you're going to see the biggest bang for your buck. Okay. And so in order to do this, in order to have these options, honestly, you have to purchase technology. And you have to purchase the technology that's going to pay off debt and build your practice at the same time for you. Okay, so what does that look like here? So when you, the dentist, start looking at purchasing technology, you start asking yourself questions, and we call these qualifying questions. And what those are how many crowns am I doing per month? You know, can I afford doing a mill? Can I afford doing a scanner? How many times am I going to turn on that mill? That might be a qualifying question for you. If you're looking at 3D imaging, do you do implants? Do you do endo? And then if you do, you're like, okay, well, if I'm doing implants, I could see where I could use 3D. If I'm doing endo, I can see where I could use 3D. You will probably ask yourself, if you're looking at getting a mill, what's my lab bill? You know, if my lab bill is $10,000 and my mill is $2,000 a month, yeah, I could probably afford that. Okay. And then you may also ask yourself, like, hey, my crowns aren't fitting correctly. I don't really like the quality that I'm getting from the lab. If I could design them myself and have total control over it, maybe I would get a better outcome. So these probably have rolled around in your head a little bit as you've thought about purchasing 3D imaging or purchasing a digital scanner or a full system CAD/CAM system, a mill. And my challenge to you is to stop asking yourself those questions, because the days of 12 to 15 crowns are gone. We used to say, okay, how many crowns am I doing? If you're doing 12 to 15 crowns, then I qualify where I can make the jump over and afford CAD/CAM dentistry. Well, you can get a really, really good crown for $100 now, a crown. So if you're doing 12 to 15 crowns a month, that means that your overhead on that is between $1,200 and $1,500. And if a CAD/CAM system is going to cost you between $1,600 and $3,000, that's just going to increase your overhead. So you're going to talk yourself out of getting a full system if you're just basing off of how many crowns that you're doing on a monthly basis. I also challenge you to stop asking yourself or stop telling yourself that you only qualify to purchase a CBCT if you do implants or endo. The way that we use CBCT now, and especially the way Plan Mecca uses CBCT now with the lower radiation, some of my best customers don't place their own implants and they don't do their own endo. They restore that dentistry, and remember, that's the single unit restorative dentistry. That's the biggest piece of the pie, but they don't place those implants and they don't drill to do that endo. Okay, so those qualifying questions end up, if you don't, you end up talking yourself out of technology that could actually really help your practice. So again, my challenge is to stop asking those questions and look at this technology different. Okay. And so the first thing that we have to do is we have to find our pain points, gain our clarity, and then that's going to help us increase our profitability. Now I'm going to take a step back in that today's lecture is about profitability, and it's about how to make up for financial losses. I know and respect that you took a medical oath first when you became a doctor, and you are a business owner second. There is nothing I will recommend in this hour that I am asking you to decrease the quality of dentistry or the quality of care that you recommend or give to a patient just to make more money. Okay, so while I am focusing on the business, and that is what we're talking about today, that is not the only thing that I'm concerned about. Like you, I put patient care first, and then I put profitability second. So I just want you to realize that while I'm not just talking about patient care this entire time, it is a complete focus of mine, and I will never recommend something that will financially give you gain that decreases quality of care for the patient. Okay. So if it's in pink, these are the questions, these are the qualifying questions that you need to start asking yourself. So what are some of the pain points I'm currently facing in my practice? Okay. If you go to our webinar page, you can actually, it's going to be a live video here. So go to our webinar page and you can scroll down, okay, and see some of our past webinars. And to help find some pain points, I highly recommend this webinar here done by Lisa Smith. You can watch the recorded webinar. And she helps find pain points and how to recover from those. And then she has she has two parts to that. And then the dentist that she works with, Dr. Darren Clark, they also did a webinar that is now recorded. They did that on Friday, and you can go to our webinar page and see this recording. And it's all about finding pain points with your patients and with your practice, and how to recover from those. And so anything that I talk about today, I highly recommend that if you want it from an aspect of a business owner and from a dentist, to go check those webinars out, because they will echo everything that I'm saying here, but again, it's from one of your peers that are saying it. Okay, so what are some of the pain points that you're currently facing in your practice? So one thing I talk about and one thing that they talk about is that, are you looking to gain or retain patients? Are you looking to, or one of your pain points that you have in your practice, do you have decreased reimbursement from PPOs? Are you working harder and making less money? Are you trying to are you trying to lower your overhead? Are you trying to increase your production? Are these creating some sort of pain in your practice? Those are your qualifying questions. And then you think to yourself, if these are some of the pain points I'm facing around my practice, maybe I am more ready for CAD/CAM and CBCT than I think that I am. Because these technologies can actually solve these pain points for you, okay? And COVID-19 just changed your pain points. If you were like, I'm good with my production, I'm up from last year, I did my 6% increase, that just changed. Okay, so again, we have time where we're slowing down, and I highly recommend for you to take a step back and figure out what your pain points are and how you're going to solve them. Okay, so if one of your pain points is that you're looking to gain or retain patients, again, I'm an educator, I research all the time, and statistics tell us is that we may lose as much as 10% of our patient base at a dental practice just through normal attrition, okay? Patients dying, patients moving. I want to tell you too, this is a really good time for your patients to break up with you. Okay, they haven't seen you in a while. They never wanted to be in your office and not reschedule their hygiene appointment. It just was an awkward conversation to say, no, I don't want to reschedule in 6 months. This is a really, really easy time that they can, if they've wanted to for a while, to go to another practice, really easy time to break those ties. Okay, so you may see that your attrition goes up just a little bit. Okay, so in a normal setting though, We lose as much as 10% of our patient base through normal attrition. So based off of what Dental IQ has said is that we need to set a goal of 15% growth to achieve actual growth. So what I ask for you is, do you know how many active patients you have in your practice? If you lose 10%, do you know what that number is? Do you know what 15% growth looks like for you? If you don't, your Plan Mecca rep can actually run numbers. We have the education to run numbers within your practice management software to see what your active patient count is. And if you set a goal of 15% growth to achieve actual growth, just to achieve 5% growth in your practice, we can tell you, okay, you have 1,000 active patients. You need to get 150 new patients in through your door on an annual basis to see actual growth in your practice. Again, if you want to gain clarity, I would start really diving deep into these numbers and putting a plan around this. So for a single doctor practice, a successful practice has to have 300 active patients in one working day. And based off of what Smart Market Dental says, and you'll look them up. I don't remember the acronym for this, but those two companies say, the AFTCO say it takes an average practice 7 years to reach a 1,500 active patient count. 7 years. So again, is there a pain point around that? What are you trying to do to get these patients in through your door that would normally take 7 years? Okay, what's your plan around that? So again, this is a qualifying question for you. What is my patient growth plan? CAD-CAM can help with that. So CAD-CAM can actually gain and retain patients, a new level of convenience for their patients. So again, qualifying question, with again, gaining clarity with what I'm currently doing today. How is that better than same-day dentistry? If I'm not offering same-day dentistry to my patients and another guy down the street can, or girl, can offer same-day dentistry, if the patient can go in there, get their crown done in 2 hours, doesn't have to come back and get numbed twice, doesn't have to have a higher incidence of post-op sensitivity because the temporary was left on there for too long. Longer you leave a temporary on, the higher the incidence of post-op sensitivity. If they can go down the street and get a more convenient service, why wouldn't they? So if you are still offering 2 visit appointments, how is that better than a single day, a single visit appointment? According to futuredonics.com, 1 in 4 of an office's established patient base, so 25%, will leave their current dentist due to appointment and office inconvenience. Can you afford that? If you have a patient growth plan, part of that patient growth plan you need to offer convenient appointments to your patients. You need to start thinking about offering same-day dentistry. So what does this mean numbers-wise? So this was an office in Louisville, Kentucky. They had bought a practice and they were worried about their patient base leaving. Because they were the new guys in town. And so we looked and we saw that they had over 2,700 active patients. They were over that 1,500 mark. There was actually 2 dentists in that practice, so they actually needed about 3,000 patients. So we looked, and the active patient value of this practice was about $575. So 2,700 active patients. They needed to get some more patients in through the door, honestly, because the two dentists that were there. But the active patient value for them was $575. So that means that if 25% of their patients left due to not offering same-day restorations or not offering convenient appointments, they would lose almost $400,000 in revenue. Can you afford that right now? Okay. So 59% of patients are satisfied with their dentist. Okay. Easy numbers. Let's say 60. 60% of your patients that are in your practice like coming to your practice. 89, again, easy math, 90% of patients with CAD-CAM are satisfied with their dentist. So if you're looking for a patient growth plan, more patients equals more production. Keeping patients satisfied in your practice, they will stay there, okay? So if you're trying to increase your patient satisfaction, what better way to do it than to add CAD-CAM? Because right here, statistics are telling us offering same-day restorations can increase patient satisfaction by 30%. More patients equals more production. Happy patients stay, happy patients talk. Happy patients get more patients to walk in through your door. And if that happens, more patients, more production. We have studied and we've seen that the average gain of marketing, the average gain of new patients when marketing same-day restorations is 15 new patients a month. So if we have 15 new patients a month coming in through the door, if we're marketing same-day restorations times 12 months, average patient is typically worth $750. It's $135,000 just in new patient revenue by marketing same-day restorations. A full system at Plan Mecca will cost you less than $100,000. That will help you gain and retain patients. And these are just statistics that are speaking. An average office has about 1,200 active patients because they're open for about 4 days. And if you remember me saying, you need 300 patients for each day that you're open. So if you can get 15 new patients in through the door, that means you just have you just achieve 15% growth. So for an average office, putting CAD/CAM and marketing same-day restorations in your practice will help you achieve your patient growth plan. Okay? So we also look at this, effect of the patient on imaging. If we look at this PA, and this patient comes in with pain, and we take a PA on them, we don't see anything, and you misdiagnose them, you say, okay, well, here's some antibiotics, they'll take them, see if it works, call me if you are in pain later on. They take the antibiotics, pain comes back. You look at this PA and you're like, I don't know what's going on. Go to the endodontist. Then they go to the endodontist. And they get endo done. Doesn't help them. They come back to you and they say, I'm still in pain. And then you send them to the oral surgeon. The oral surgeon takes an image and actually sees that tooth should have been extracted. So not only was that patient in your practice 4, 5, 6 times, and they were in pain that entire time, and you were misdiagnosing them, and you used up their insurance benefits. What does this do for patient satisfaction? So when we look at the accuracy of digital sensors, and I sell digital sensors, intraoral sensors, there's a place for them in the market. However, there are studies showing that they're only 25% accurate. There is a 75% chance that if you take a PA, you will come to the wrong conclusion of diagnostic treatment. There's another study showing from the AAE and the AAOMR that an accurate diagnosis was reached 36 to 40% of the time when you took an intraoral radiograph. However, if you could take a CBCT, your accurate diagnosis was reached 76 to 83% of the time. Just by putting CBCT in your practice, you double your accuracy. Well, if you can double your accuracy, what do you think that's going to do for your patient satisfaction if you're accurately diagnosing and treating them? This study shows that 62% of the time, treatment plans change when a doctor sees a CBCT versus an intraoral PA. This study, they took PAs, showed an endodontist, and then they took 3Ds, showed the endodontist, and they said, would your treatment plan stay the same? And 62% of the time, the treatment plan changed. So if you are only accurately treatment planning your patients 40% of the time, what is that doing for their satisfaction? Again, this goes into your patient growth plan. This says 53% of the time treatment plan changed. That when a doctor actually saw the CBCT, he changed the treatment plan 53% of the time. Okay? So again, how satisfied are your patients when you misdiagnose a problem? If you are only 25% accurate, these again, in pink, these are your qualifying questions. If you're only 25% accurate in your diagnosis, what is that doing for my patient satisfaction? And how does this affect the patient insurance? How does it affect their job? They cannot take time off of work. Treatment plan changes 52 to 63% of the time when a doctor sees a 3D image versus a 2D image. So my challenge is to you as well is, can you, the dentist, afford a misdiagnosis at this time? Is this efficient for you? Is it efficient to have a patient sitting in your chair 5 to 6 times when you still don't know what's going on with them, or that you did treatment for them and then it's not working, and so then you have to send them off someplace else, or you have to reimburse them some money just so they don't get mad at you? I urge you to change your normal. Your normal doesn't have to be an accurate diagnosis. Your normal doesn't have to be sitting there scratching your head and saying, I don't know why this patient is in pain. I don't know why my treatment just didn't work. Because there's technology out there that will change that normal for you. Okay? But then a lot of people say, okay, fine, I'll buy CBCT, right? And I'll just start taking more CBCT images. Well, based off of these different councils and organizations, you can't do that. There are certain rules of engagement that says you can only take a CBCT when necessary, and you have to limit your field of view. So if one side of the patient is hurting, you can't take an entire image, okay? CBCT image is too much radiation. You have to take a PA first, and if you can't diagnose from the PA, then the rules of engagement say, okay, now you can take a CBCT, but you have to just to limit your field of view just to that area of concern. Because if you look at a digital PA, it's 9 microsieverts. If you look at a standard 3D dose, it's 46 microsieverts. So why you can't just go take 3D doses every time somebody comes in with pain. But a Planmeca CBCT or 3D PA, we lower the radiation by 77% without any image degradation. So we can actually take a 3D PA for 3 microsieverts. So now you can get rid of your 2D PAs and start taking your 3D PAs so you reach diagnosis, an accurate diagnosis faster. You also don't, because the radiation is so low, you don't have to limit your field of view just to this area. You can actually take an image of both jaws at the same time to see if anything else is going on with that patient. And we'll get into more of that later. But if CBCT can accurately give us a better diagnosis, how is that going to change the satisfaction for your patients, and how is that going to make you more efficient? Futuredonics also says 1 in 5 patients will choose a dentist by their high-tech offerings. So if you can put more high-tech offerings in your practice, there's a 20% chance a patient will choose you to be their dentist. Again, all part of your patient growth plan. Okay, if PPOs is a pain point, your fees, so when we look at a PPO, your fee should actually be 3 to 4 times your cost just to keep up hourly production. So that means for an average dentist, you need to charge $1,800 for your crown. That's what I'm saying. If you're not a PPO dentist and you're a fee for service practice, you are not going to be able to charge $1,800 just for a single unit restoration. Okay, so you are still not maximizing that production because you just can't charge enough. You can't charge actually what that crown's technically worth, which is $1,800. You can't charge that. Okay, so impossible for a PPO, and honestly, it's impossible for fee for service. So how do we start making PPOs more efficient? If we can't charge more, we have to start maximizing that patient appointment time. So the first thing is that we have to get rid of the 2-visit appointment. It is a boat anchor. That is 30 minutes of chair time that you are not charging the patient anything if you have a seat appointment. It can cut your hourly production in half, and what we'll see here in a little bit is that you can actually see what it's going to do to your specific production. We can run a report to see what a 2-seat appointment does to your hourly production and how it's a boat anchor for you. So that's exactly what we can do. We also getting rid of the second appointment, but then we start making these crown appointments super efficient by running 2 revenue producing appointments at the same time. It increases your efficiency and it increases your productivity. What does this actually mean? Is that an average CAD/CAM dentist is $7.50 per hour. An average ADA dentist does $4.50 an hour. So just by being super efficient in these crown appointments, and again, the biggest piece of your pie, those single unit restorations, you can increase your hourly production by 67% just by being more efficient in those appointments. That's how we start maximizing PPOs. Okay, so how do we do this? Or why do we want to do this? First of all, if you take a 20% reduction in PPO fees, it can actually create a 50 to 80% decrease in profits. What are you, again, qualifying questions for you, dentist, what are you going to do to make up for that? So how does this actually work out? Okay. So when we look at this, no PPO with a PPO, if you charge $1,200 for a crown, and then you go and do, and then the PPO says, nope, sorry, you're going to take a 20% hit, or we're going to adjust the fee by 20%. You can only charge $960. An average office, no matter the specialty, your overhead, it should be around 75%. Okay, I don't care if you're an orthodontist, oral surgeon, GP, whatever. Typically, your overhead is 75%. So that means your overhead on that crown is $900. So that means if you took a 20% deduction in your fee, your overhead didn't also go down by 20%. It stayed at 75%. So you can see here that instead of making $300 on this crown, you're going to make $60. That's an 80% decrease in profits. So that's what I'm saying, is that when you're starting and you're looking at your practice and you're getting clarity around it, and you're like, I need to produce more, I need to fight these PPOs. Every time you take a 20% adjusted fee, it's an 80% decrease in your profits. How are you going to make up for that? What is your plan? Okay, so we can use imaging to help make up for this. So the first thing that we do, like I said, option A, we can diagnose more restorative dentistry. If you use Plan Mecca extra oral bite wings, you can diagnose 50% more caries. If you can use ultra low dose, again, if we can lower radiation by 77% and lower radiation on a CBCT on 3D imaging, and we can lower it less than that of a 2D image, we can now use CBCT in a completely different way than when we're used to. So that means that every time you take a CBCT, you actually have a 50% chance of finding something else in that patient's mouth that they need to have done, maximizing the patient appointment, maximizing your current patient base. If me, the patient, walks in and I have pain on this site, and you take a 3D image for 9 microsieverts of both my upper and lower jaws, and you actually see I need endo done on these teeth and I need an implant done on this tooth over here, that's maximizing the patient appointment. So if you can take a CBCT on these patients, there's a 50% chance you'll find an incidental finding, an asymptomatic something. Also, if you can use extra oral bite wings in CBCT, you have a 28% chance of finding, or there's 28% more lesions, asymptomatic lesions, that you can find. How do you treat a lesion? Endo implants. Even if you send those out, they're going to come back to you, the dentist, to have the restorative dentistry done, those single unit restorations, the 36% of your practice. That's diagnosing more. And we can actually see what this means for your practice, because this contributes to the biggest piece of the pie. And when you look at return on investment on CBCT, it can be millions. Okay. These are just, again, educator, I'm backing up what I have to say. This is the study from the University of Minnesota showing that a pan bite wing was double the caries detected by the intraoral bite wing at all depths. This is incidental findings. Consistently, 50% of the time, there's a incidental finding if you can take a CBCT image versus a 2D image. This is 28% lesions. 1,000 patients, saw 28% of those patients had an asymptomatic lesion, and 2D intraoral is not going to pick it up. You need extra oral bite wings and or ultra low dose CBCT. Okay, patient comes in, there's their intraoral bite wings, there's their extra oral. Plain as day. 28% more lesions. This patient is Steve. This is extra oral bite wings. Steve has no pain. You say, okay, looks good. See you in 6 months. That's $0 in a treatment plan. You take extra oral bite wings. There's $750 in treatment. Or sorry, yeah, $1,750 in a treatment plan. You're gonna do endo and a crown there. Now, what if we can take an ultra low dose CBCT? So CBCT confirms we do have this treatment that needs to be done, but look, we didn't have to limit our field of view. We can take an entire jaw scan because the radiation is so low on a Plan Mecca CBCT, and we don't lose image quality when we lower the radiation. We're the only ones on the market that can do that. So because we didn't have to limit our field of view, look what else we found. We found internal root resorption on tooth number 22. That's an extraction and an implant. If you're doing the implant yourself, And the crown is $3,000 more. So that treatment plan just went up from $1,750 to $4,750. That's maximizing and diagnosing more dentistry that contributes to the biggest piece of the pie. This is how we start hitting the ground running, is that when our current patient base is sitting there, we're taking more efficient images that can diagnose more for less radiation, okay? So 50% more caries, 28% more lesions, 50% more incidental findings, and we're twice as accurate. So if you're diagnosing more dentistry and treatment planning more accurately, you are producing more dentistry, okay? How can CAD-CAM help with your PPO issues? Is that, like I said, get rid of the boat anchor. If you have 30 crowns per month and you sit chairside for 30 minutes, for each one of those crown appointments, that means that you're working 15 hours for free. You cannot afford that right now. 15, and you're supposed to be making on average $450 per hour. And you just gave 2 days of dentistry away for free. You have to maximize doctor time, okay? That's how we start making up for this lost production. So this is a sample appointment schedule. It says NUMP. I know every time I look at this, I'm like, I need to change it. It's supposed to say NUM, not NUMP. But this is what your appointment schedule looks like when you do same-day dentistry and you mill out your own restorations. So when we look here, you are in chair. This is a 1 doctor practice, 2 hygiene, 2 operatories. They're the doctors working out of. You are numbing and prepping up here. You block out the time here because we can't be in 2 places at once. And then you, the doctor, leave and go to chair 1 after you've numb and prepped in chair 2, and you are going to do other dentistry here. And then you have your assistant stay here, and she's going to scan, design, mill, stain, glaze, polish, and mill out your restoration. She's going to do the initial try-in, make any adjustments that she needs to make, even though that should come out of the mill fitting because you've made the adjustments proactively through your design phase. And then you, the dentist, are just going to come back out here and you're going to seat. And you're just going to do this all day long. So now we have 2 revenue producing appointments going on at once. Okay. Here's an example. I won't go through it bit by bit, but here's an example of a dentist that did that. These are crowns 13 and 14 side by side. So we look at a traditional restorative treatment setting, 2 visit appointment, and we look at a CAD-CAM setting. We're saving time, we're saving money, we're maximizing our hourly production here. We're increasing that. But look at the doctor downtime. In a traditional setting, your downtime on doing crowns 13 and 14 side by side is 15 minutes. Here, it's 45 minutes. What can you do in 45 minutes? You can do more direct restorative dentistry in the second chair. So this dentist is out of New Jersey, Dr. Krieger. He does something called $1 Million PPO. Highly recommend looking into it. And when he uses CAD-CAM dentistry, so he produced another $565 in direct restorative dentistry in his second chair in that 45 minute of time. So in this 2-hour span of time, he produced the $1,722 off of the PPO fee from crowns 13 and 14, but then he did another 565, so he increased that by $2157 in that 2-hour span of time. That was $435 in additional revenue per hour. Okay, so got to be super efficient in our appointment times to make up for lost time and help fight for these PPOs, okay? Maximize doctor appointment time. Get rid of the second appointment, run 2 revenue producing appointments going on at once, okay? How do we lower overhead? Quickly. Your lab bill is about 6 to 8% of your overhead. CAD-CAM will put 3% back into your pocket immediately. Okay, in about 2 to 3 months, you should see about a 95% reduction in lab bill. If I could tell you if I can put 7% of your office overhead back into your pocket in the next 2 to 3 months, would that help you in your current situation? Probably. Again, qualifying question, is a pain point of mine overhead? I highly recommend, if it is, looking into CAD-CAM. because for an average office, by cutting overhead in your lab bill, it typically means about $45,000 annually that you're putting back into your pocket. We can actually run reports, Planmeca reps can, to show you how you can actually lower overhead by using CAD/CAM. So this is how it all breaks out. I'm running through this super quick, but basically the overhead that you have wrapped up in a single unit restoration is $184. Cost of a CAD/CAM restoration is $35. Again, it's in pink. So this is something you need to ask yourself or tell yourself. By offering same-day restorations in your office, you can cut your single unit materials overhead by 81%. This savings alone can often cover the cost of a full system. So again, if overhead is something that you're trying to affect in the next 6 to 9 months, highly recommend decreasing your overhead on your single unit restorations, because again, it's the biggest piece of the pie. You're going to see the biggest bang for your buck there. If you save 10% on your merchandise on for an average office, if you save 10% of your merchandise, this equates to about $3,000 a year. If your dealer were to give you free service and parts, this is about $3,000 a year in an average savings. However, CAD/CAM can conservatively save you $3,000 per month. So again, you have to start really getting clarity and focusing on different things in the next couple of months. I'm not saying don't look at how to save in service and parts and save in merchandise, but where are you going to get the biggest bang for your buck? And it is by putting CAD/CAM dentistry in your office to decrease your overhead. Okay. And the final thing is that you need to start doing onlays, or some offices call them crown lays. Okay. And why? Because composites are driving down your hourly production. So if you're supposed to be making $4.50 an hour, but on an average basis for a class 2 composite, you're making $189 an hour, and it's taking 45 minutes to an hour to place that, you just lost $200 an hour. And for an average dentist, you do that 4 to 5 times a day. Class 2 composites are a necessary evil, and I understand that. Trust me. I live in Kentucky. We have stuff, we have a lot of stuff going on in patients' mouths here. We have a little joke that we have March Madness teeth. We're down to the final 4. Okay, so I understand that class 2 composites are a necessary evil. Totally get it. I live and breathe it every day, and so do my offices. But there's a lot of times that you have these large class 2 composites that you could change over to an onlay or change over to a crown lay. And you have to figure out how to stop doing so much dentistry that's drowning you and start doing more of this of dentistry that's going to build up your practice. Okay, so how do we do that? Also too, side note, why do you want to do onlays? They're going to last you 20+ years versus composites that's going to last you 5 to 8 years. And that's Gordon Christensen that says that. Okay. So again, it's in pink, something you need to ask yourself to get clarity on. You are not making any money off of class 2 composites. You are actually decreasing your hourly production by 30% every time you place it to class 2 composite. So if you want to hit the ground running, if we want to make up for lost time, if we want to make up for lost production, we have to figure out how to not stop doing so many class 2 composites. Because in order to survive, we have to keep our hourly production up. We have to, okay? So why don't you do onlays now? I know why. I don't know how to prep for them. I only learned it once at my dental school. Do I get insurance reimbursement? Yes, you do. Talk to your Planmeca rep. We can walk you through that and help you with that. They do reimburse now. You can also, if they don't reimburse for crown or for onlays, they will reimburse for something called crown lays. Again, ask your Planmeca reps. They can put you in touch with doctors that do this day in and day out. We'll teach you how to prep as well. We have trainers that will teach you how to do that. Will my patients accept it? Yes, they will. Again, you have to change the normal for them. The normal for them is that you put a class 2 composite in there and it's a big filling, and you know as well as they know is that they're going to have to come back in the next 5 to 8 years to have a crown done. Change that normal. Patient, I can put something in your mouth that's going to last you 20+ years versus 5 to 8 years. Is it going to cost you a little bit more? Yeah, it is. But you know what? If anything goes wrong with that restoration, I will replace it for you at no cost. You just need to come see me every 6 months and have your hygiene appointment so that I can check up on that restoration to make sure that it's okay. And if it's not okay, I'll replace it for you at no cost. You just did 2 things there. They accepted the treatment, they got a better restoration, but you just gained a hygiene patient for life. Okay? And then a lot of doctors will say, well, if I'm gonna do an online, why wouldn't I just do a crown? Because the whole point is that we want to, if you're doing 45 minutes to an hour on a composite, then we need to take the same amount of time and we need to maximize that time. If you do a crown, even if you're doing it same day with a mill, typically that appointment will take you an hour and a half to 2 hours. Yes, that will be more reimbursement for you, but it will cost you more time. Okay, so where an onlay, we can use, it's called a nano ceramic, and we can use a material in which you can bond to existing enamel and you don't have to fire it. And so it's super strong when you can bond it to existing enamel on the tooth, but we don't have to fire it, so we're saving time there. You just polish it up in the mouth and it's beautiful. So it's the same amount of time, 3 times the amount of profit. Okay, I have a doctor in rural Kentucky. He does not do any crowns anymore. He only does onlays and crown lays, and it's because of this reason right here. Class 2 composites were drowning him, and he had to figure out a way to make up in revenue. And so now he's saying too, he's like, not only am I doing the dentistry that I want to do, but I'm seeing more of the dentistry I want to do because I have more options to give the patients now. We have another option if we can start doing onlays, but we're going to do them in office. We don't want that to be a 2-visit appointment. We don't want to send those out to the lab. And his patients are motivated to say yes if you can do the treatment plan the same day. There's a lot of times patients will come into a hygiene appointment. He will diagnose a crown lay or diagnose an onlay and says, hey, do you have an extra 45 minutes? I can give that to you right now. And these are the benefits of that treatment. So he sees that his patient acceptance goes up when he can offer the same day treatment. Okay, same amount of time, again, 3 times the amount of profit. This was an offer. Every time they placed a composite, they were losing 36% reduction in their overall hourly production, decreasing their hourly production by 36% every time they placed a class 2 composite. But if they could just convert 20% of those composites over to onlays, you just need a cusp involvement and a buccal involvement, or cusp or lingual. That's all you need, cusp, buccal, or cusp lingual. And all they had to do was convert 20% of those over. There was only 9 a month, and they increased their hourly production by 158%. Do you think that would help you in the next 6 to 8 to 9 months if you could increase your hourly production by 158%? You have to start offering more, like a more productive dentistry. You also have to use an imaging system that's diagnosing the dentistry that isn't drowning you. So again, here's this study, but look at what we're looking at now. We look at all depths. How many times have you taken a bite wing and seen some decay, and then you go chairside and open up that tooth, and it's so much bigger than what you actually thought that it was, and you're like, probably would have diagnosed this as a crown. But now the patient's there, they're numb, they already had a treatment plan. I'm not going to go sit them back up and tell them they have more money, and I don't know if their insurance is going to cover it, and we've got to run that. I'm just going to go ahead and put this big composite there, cross my fingers, and I know they're just going to come back and we'll do a crown later when it breaks or when it fails. Where if your intraoral x-rays are not accurate at not only diagnosing the amount of caries, but at diagnosing accurate depth. Just the nature of the beast, where extraoral is. So if we take those same extraoral, look at that decay. It's going all down the DJ. Decay is so much bigger than what we realized, but these images didn't show us that. We thought that was just a small composite. And here, this would have actually been diagnosed as an onlay. So get an imaging system that is going to diagnose more of the dentistry that you want to do. Okay? So the Plan Mecca Pro Max bite wings shows more bone loss than intraoral. and 20% more surfaces than intraoral. If you can see more, you can diagnose more dentistry. ProMax bite wing, you can see 24% more teeth than intraoral bite wings. You're going to diagnose more dentistry. ProMax bite wings doubles your caries detection at accurate depths versus intraoral bite wings. You're going to diagnose more dentistry that isn't the composites. They're going to be the crowns. They're going to be the onlays. Did you know a ProMax bite wing, extraoral bite wing opens up contacts as good as intraoral? We're the only ones on the market that can do that. We're just as good at opening up contacts as intraoral. So you're not sacrificing image quality or diagnostic quality. And it's significantly less radiation. So it's also safer for the patient. So again, I don't care if you don't place implants or you don't do endo, you restore those, and that's profitable. So if we, like with the 28% more lesions, or diagnosing our caries, our 28% more lesions, even if you're not placing those implants, and even if you're not doing that endo, they're going to come back to you and get that crown done. If you're charging $1,000 for a crown and it's a 30-minute seat appointment for you, just made $1,000 in 30 minutes versus losing $250 off of composites every hour. That's how we start fighting some of this and maximizing our patient appointments and making more production. Because if you can do 2 of those in an hour, that's $2,000 an hour. Okay? So this is what one of our ROIs look like. This office has an active patient count of $4,200. I'm sorry, active patient count of 4,200 patients. And if you look here, they have asymptomatic lesions per year. 28% of patients have asymptomatic lesions. You just don't have an image modality of seeing it if you don't have ultra-low dose and if you don't have extraoral bite wings. So that means for this office, almost 1,200 patients are walking out through the door with lesions that need to be treated. Even if they don't do the endo, even if that GP doesn't do the implants, they're going to come back with that restorative dentistry and get that crown done at that office. So that's $1,000 in restorative dentistry. You doubles your caries detection. That this office is going to do 932 more caries. Average fee for caries is $265. 50% more incidental findings. 50% of patients, if you can take an ultra-low dose CBCT on them, you're going to find an incidental finding. You're not going to treat all of those. Maybe you'll treat 20% of those. That's still $421. And typically, average fee for those findings is about $1,000 in production. So if we multiply these numbers and add them all up, an annual increase in production just by doing ultra-low dose CBCT scans on your patients, on your existing patient base, and extraoral bite wings is $1.8 million a year. 5-year profitability for this office on a PlanMec or ProMax is $9 million. I increased their revenue by almost 83%. That would increasing your revenue by 83% over $1.8 million a year help you? Probably. And all you have to do is just press the button to do a better image with image quality and diagnose more dentistry on the patients that are in your practice. Do CPAs agree? Absolutely. This is a Crossroads Tax Advisors. They say when you can take a CBCT versus a 2D image in just one scan, there is about $14,000 of treatment indicated that may not have been easily identified otherwise, because CBCT is more accurate. It also says that based off of your depreciation benefits, you can, off of those depreciation benefits, 45% of that machine is paid for. That's not even talking about the increased production that you get off of it. So talk to your CBCTs about this type of capital equipment, okay? So dentists can keep the largest, make the largest piece of the production pie and make it more profitable by keeping patients satisfied in their practice, decreasing their overhead, and increasing their hourly production by maximizing appointments and efficiency. And that's by diagnosing more dentistry, lowering your overhead, and doing that dentistry more efficiently. Okay. So quickly, running just a tad bit over here. This is an office I did a case study with in Nashville, Tennessee. This is Lisa Smith that I talked about earlier, as well as her doctor, Dr. Darren Clark. They bought this practice so we ran some reports, and this is when they did not have any technology in their practice, okay? So year that they bought it, year 1, year 2, in their 3rd year, they decided to buy CAD-CAM. And look what happened to their revenue. Revenue went up. Look what happened when they started doing 2D and 3D imaging. Revenue went up. Look what happened when they started diagnosing more onlays because of their 2D and 3D imaging protocols and doing those with their CAD/CAM system in their office. Look what happened to their revenue. Look what happened to their porcelain units. CAD/CAM, when they implemented this, then when they implemented their 2D in year 4. Now in year 4, it was in November, December when they got their 2D and 3D system, their Planmeca Pro Max, and they started doing extraoral bite wings and ultra-low-dose CBCT health scans on patients. So we really saw what the 2D and 3D imaging was doing for them in year 5. Look at their increase in porcelain units when they started diagnosing more dentistry in year 5 here. And then they were doing that dentistry more efficiently, same day. So they were maximizing the dentistry that they were diagnosing. And they started clearly doing more onlays. Their diagnostic revenue went up by $42,000. Their patients were just more apt to say yes to imaging that was safer for them and got them better diagnostic outcomes. And Dr. Clark doesn't do endo. But if he did, he saw that when he started doing ultra-low-dose CBCT scans and extraoral bite wings, his endo would have gone up by $160,000. Look at that jump. So the year 3 is when they got CAD/CAM. That's when they started implementing their 2D, 3D unit. That's just their endodontics. And this is their actual restorative revenue. So they wanted to grow 6%, which is in the red here. They wanted to grow by 6% every year. That was their projected growth. But look what happened to their restorative revenue when they implemented CAD/CAM and when they got their 2D and 3D imaging. And they started diagnosing more dentistry and doing more onlays. So in those years that they started diagnosing, and this was on their active patient count already, this wasn't even new patients, their restorative revenue went up by $1.2 million, not to 1.2 million, went up by 1.2 million. Look at their periodontal revenue when they started implementing 2D and 3D imaging. $450,000. Okay, so my point in saying this, again, to fight this battle, this uphill battle that we've always had, but that we're going to have even more now because we've been shut down for the last 5, 6, 7, 8 weeks. Would this help your practice? When you have clarity around what your issues are in your practice, would this help you? Would it help you if you could increase your porcelain units by 30% the first year that you have your CAD/CAM system? Would that help you? Would it help you if your porcelain units went up by another 32%? So this was the results that Dr. Clark had. Would it help you that your diagnostic revenue goes up by $42,000? Would it help you that you increase your restorative revenue by $1.2 million when you start implementing low-dose and extraoral bite wing imaging protocols? Would it help you if your endo diagnosis went up by $159,000 in 2 years? Would it help you if you could increase your perio production by $450,000? So this is what I'm telling you, is that take a step back, figure out what some of your pain points are, and truly start implementing the technology that's going to help fix those pain points. Okay? Quickly, if we want to just go over questions, and I'll just quickly, as we're doing that, I'll show the the Excel spreadsheet that we can run for offices. Jody, if you want to.
Yeah. Okay. Yep, no problem. We've got a few questions. So just a few things before we get started. If you have questions for Erin specifically, please submit them via the Q&A function at the bottom of the Zoom page. It will help us go through them and dismiss them as they are answered. It's much more effective than using the chat feature. Additionally, we will be posting the CE survey in the chat function. It is posted now. As I mentioned earlier, if you have issues with the link, we will send it to you via an email, not immediately following the webinar, but once the recording is available and we have all of the attendees outlined. So it'd be later today or tomorrow. Again, we will email the link if you have issues. Okay, so questions. First one was related to extraoral bite wings. I know that you mentioned at the beginning of the course that we aren't coding experts, but we have a question on how you recommend coding for extraoral bite wings.
So there is an extraoral bite wing code. So what my dentists do is that they will do the extraoral bite wing code. If you don't have the book, the Charles Blair book, Coding with Confidence, I highly recommend to get it. You'll see the extraoral bite wing code in there. You can also clearly Google it. And then typically in the comments, my dentist will say, if you do not recognize this code, or if this code is not available, please bill out as, and then just use your normal bite wing code. It's not been a problem. But again, I'm not an expert. One thing that I would recommend is this is the same question that Dr. Clark and Lisa got in their webinar. And so I would highly recommend to go back onto our website and go watch that recorded webinar, and they address that as well.
Yeah, and you can also look at the medical billing one that we did through DevDent. They touched on some of it as well. And at least if you're looking for advice, there's somebody that you can talk to on that side from a billing perspective.
Yeah.
All right, and we had several questions about onlays. So the first one is, I agree with the onlay versus composites clinically, but I have gotten burned several times with insurance companies not covering onlays when they will cover crowns.
Okay.
Besides having a great benefit breakdown.
Yeah, so again, you can always ask your Planmeca rep. We all have the same information, and we just got it from the Coding with Confidence book of Dr. Charles Blair. No, he's not sponsoring this at all. I've worked with that book for 9 years and trust it. But we'll go through step by step of how to do the how to do the narrative for that restorative dentistry. Your Planmeca reps also have access to cover letters that you can put with. It's just a generic cover letter, and of course you just make it relative to that patient. And typically my doctors will send out with the narrative from the Charles Blair book, as well as the cover letter. They will typically get payment for an onlay as they do for a crown. Now, the dentist that I was talking about in rural Kentucky, I actually just talked to him last week, and he said that he bills it out as a crown lay. He does a crown lay. So that's another option, and that's just the amount of cusps that you have involved, whether it is a crown lay or an onlay, and he has no problem with that reimbursement. So again, I can't tell you how to code, but to be an onlay, it is one cusp involvement and a buccal surface or a lingual surface. To be a crown lay, you have to have 50% involvement. So, and again, I work in Kentucky and Tennessee. We don't have a lot of teeth here, and these are how my dentist uses the system.
Okay, do you want to go to your calculator sheet and come back to questions? Okay, go ahead.
Yep. So if you ask your Planmeca rep, they can run these codes for you. So we just run a few codes here that you can see, and we punch those in. And then we run your total production, as well as we type in, okay, what does your lab charge you for a crown, and then how many providers do you have? Okay. So that's all that we're looking at here, and then it auto-populates this for us. So basically, what we look at is, how many crowns is this office doing per month? And this office was doing 13 crowns a month, and they were, with shipping, it was $115 a unit. So their savings just on their lab bill, if they could use a full system, would be $1,500. Then when we looked at here, this office, if we could eliminate the second appointment, so if we're doing 13 crowns for free, this is a rounded number, this was about 7 hours of free dentistry that this office was doing with their seat appointment. So this specific dentist was worth $292 per hour, so a little bit lower than an average dentist. So based off of that, this dentist could put another $2,000 in that chair time if we could get rid of that second appointment. Okay, so basically this dentist was just giving away $2,000 a month for free, and just free dentistry because of that second appointment. And that's 7 hours we could have put revenue producing dentistry there. For this dentist, all the 20% conversion fee to onlays was 4. So if she could just do 4 onlays per month as a 20% conversion, and the fee difference between a composite and an onlay for her was $618, this was an additional $2,400. And then value of a patient for this office was $610, so a little bit lower than an average office. And like I said, average new patients when marketing same-day restorations is about 15. So if we get 15 new patients to walk in through the door, that would be an additional $9,000 for that office. So when we add up these 4 numbers, the cash flow for this office was $15,000, and then we have to pay on the system, which the Plan Mecca system is about $1,600 to $1,700 per month. And so the net revenue for this office on a full system CAD/CAM unit was $13,000 per month. On an annual basis, the net profit for this office is $160,000. So we increased her overall revenue by almost 26% and decreased her overhead after she paid on the system by almost 4%. Her return on investment on a full system was 699%. So I just popping over here to the composites. Every time she placed a composite, she lost 18% in production. If she could start doing onlays, she increased production by 264%. So just more motivation to do onlays. And all this was 1 a month for this. I'm sorry, 1 a week for this office. Just 1 a week, and it's an additional $2,400 in production. For this office, she was originally looking at scan only. And so if she just would have bought a scanner and not have a mill or a CBCT attached to it, she would have actually decreased her revenue by 5%, almost, well, 4.5%, just because she wasn't doing enough dentistry to make that technology make sense for her. And again, these are numbers we can run for your office. Just ask your Plan Mecca rep. And then this is the extraoral imaging. So average number of patients is 2,000. She was a little bit over average on patient count, but 28% of asymptomatic lesions, 28% is 570 patients for her. And the average restorative fee from those lesions, she doesn't do implants, doesn't do endo, that would just be restorative dentistry, would be $798 on 570 patients. Doubling the caries detection, and this is the average fee for her for caries, and then 50% more incidental findings. She's only going to treat about 20% of those, but the average fee for those incidental findings is $798. So just by doing extraoral bite wings and ultra low dose imaging on her current patient base, her annual increase in production was almost $660,000. And her 5-year profitability on Plan Mecca Pro Max was $3.2 million. So I doubled her revenue in a year. And again, talking about things that could help you. And then one thing that I always ask my doctors is that over the next, and I'm just taking an average of what a Plan Mecca Pro Max costs. So you may get one that's a little bit less, you may get one that's a little bit more, just depending on your needs. But, you know, on average, do you plan over the next 5 years to invest $88,000 over 5 years? Buying rental property, 401k, Roth IRA, you know, we're going through all that stuff right now with taxes. And I bet you will. You know, I bet you plan on investing less than $20,000 a year for the next 5 years. But my question to you is, where could you invest that could turn it into, in 5 years, turn that into $3.2 million just by pressing a button? And at the same time, keeping the radiation extremely safe for your patients. So this is what one of our ROIs look like. So we can actually run this for your practice to see what your return on investment would be for technology.
Hey, Erin, somebody asked if you have a similar analysis for orthodontic practices.
So orthodontic practices are a little different in that typically your incidental findings you are not treating. It may change your treatment plan, but you're typically going to refer that dentistry out to an endodontist or oral surgeon before you start your ortho. So as far as this return on investment analysis, no. Where you would see that is case acceptance, as well as, you know, like my orthodontist that I go to, Dr. Jay Burton, he has this and he charges out a certain amount for his CBCT images. So if you have like 12 new starts on a monthly basis, you can more than afford, and you're charging your patients out for those scans, you can more than afford CBCT. And then again, you'll see that your case acceptance typically goes up, but you're not going to treat any of those incidental findings. And of course, you're not treating caries. But typically what we look at is about 12 new starts is the happy point of the system paying for itself for orthodontists.
Great, thank you.
Mm-hmm.
Did you have more you wanted to cover before we answer more questions?
Nope.
All right. So a few more questions. Patients always ask me how long an onlay or a crown will last. Can you give some ranges?
So according to Gordon Christensen, a CAD onlay, so doing it same day off of a CAD CAM system, will last 20 plus years. Okay. Now you need to bond that in, okay? So with a crown, it depends on the materials, it depends on your prep, it depends on if you're cementing it in versus bonding in. You know, if you're bonding in a crown, an EMAX crown, you are doubling or tripling the strength of that crown. So versus just traditional cement. So the crown one is a little bit, relative based off of the type of material and bonding technique that the dentist is doing. But Ivoclar has done a study on crown, on EMAX crowns done on our specific CAD-CAM system, and they saw less than a 2% failure rate over a 10-year period of time. And that was only with a millimeter of reduction.
All right. So there's another question about onlays that she hasn't had luck seating same day onlays. Do you have any recommendations for materials? And do you recommend for onlays that used to be with Lava Ultimate?
So I do recommend Lava Ultimate. If they're not seating, if it is so every mill every chairside mill has different accuracies. So if it is not a Plan Mecca mill, it could just be an inherent issue of your mill and the accuracy of it. If it is a Plan Mecca mill, it is probably just prep or design technique. So again, I would reach out to your Plan Mecca rep. We have a lot of resources for prep design and design technique to get you the onlays that they should fit like a glove. So it may just be a little bit of a training issue if it is a Plan Mecca mill. If it's not a Plan Mecca mill, it still could be a training issue, but it also could just be an accuracy issue of your mill.
Great, thank you. And then the last question, do dentists need further training on reading extraoral bite wings?
No. They don't necessarily need additional training. So I will say this: if you have extraoral bite wings, or you get a Plan Mecca Pro Max and you look at the extraoral bite wings, you will immediately say these don't look as clear. And that is true. They look a little, the clarity doesn't look like it's as good as intraoral. However, clarity doesn't mean accuracy. So it will take your brain or your eye just a little bit to be used to seeing an extraoral image versus an intraoral, just from a clarity standpoint. But you will see a huge difference in your depth and your caries detection, and you should not have to have any additional training for that. It's just, it's just going to take you a little bit to get used to it, to kind of wean yourself off of the intraoral clarity. But again, clarity doesn't mean that it's accurate. Just because it's a pretty image doesn't mean it's an accurate image. And as long as your extraoral bite wings, as long as it's being set up correctly and the patients are positioned correctly in the machine, you honestly should like the image quality better than you will intraoral.
Great. Oh, wait, we just got another one in. How much time do you need to mill an onlay?
I'll go on a really high side and say 8 to 12 minutes. but we don't have to fire. So as soon as that comes out of the mill, you can pop that right in the patient's mouth, bond it in, and polish it up. I have one in my mouth. It's beautiful. Didn't have to do any adjustments to it. And I was in there for less than an hour.
All right. Thank you so much. That concludes today's webinar. Erin, thank you so much for the helpful information. Hopefully we got all of your questions answered. For those of you that were having issues with the CE link, I did provide an email address for assistance. Otherwise, you will receive an email later today with the recorded link and your link to the survey. Thank you so much and have a great afternoon.
Yes, yes. And again, please reach out to your Plan Mecca rep if you want an ROI ran for your specific office to see if this technology could help you out in the future. Okay.
Great. Thank you.
Thanks. All right. Bye-bye.